So let's change our focus from the perioperative setting to the postoperative setting. And also over the summer, the Gortec trial was presented at ASCO, which is the big oncology conference in Chicago each year. And so this phase 3 trial asked an important question for patients who receive surgery and have high-risk disease, which was defined earlier. Patients were randomized to either standard of care radiation therapy concurrently or at the same time as platinum-based chemotherapy, or in the experimental arm, patients received nivolumab, which is an anti-PD-1 inhibitor, and it was given at the same time as radiation therapy and cisplatin. And so, Dr. Rosenberg, can you summarize the key findings of the Gortec trial?
Yeah, so the Gortec trial, which you described, was looking in patients after surgery. So that differed from the 689 trial. And it looked at patients after surgery, particularly with high risk disease, which we've, I think, defined previously, but included patients with positive margin or extranodal extension after surgery, in whom the standard of care would be cisplatin with radiation. And that was indeed the control arm of the study, with the experimental arm being, as you mentioned, giving a dose of nivolumab before, during, and after chemoradiation. And this uh, uh, trial was also positive for the primary endpoint, which I believe was disease-free survival. But you guys correct me if I'm wrong. And that's, an analogous endpoint to event-free survival. Again, measuring how patients were alive and without disease in comparing the experimental arm versus the control arm. And so this complemented the data of 689, but rather than being in the perioperative setting, this particular trial was looking in the adjuvant setting, meaning after surgery.
And Dr. Kazmar, so one key difference between the Gortec and Keynote 689 trials is that in the Gortec study, the first dose of nivolumab was given prior to starting chemoradiation therapy, while in 689, pembrolizumab was given at the same time as chemoradiation therapy. What's your thought on this, and does it matter? And if so, why?
Yeah, it's a tricky one. I mean, I think in terms of the Keynote 689, the idea, I think, for both is you're priming the immune system one way or the other. In the neoadjuvant phase of the Keynote 689, you're clearly giving immune therapy while there's tumor intact, which theoretically makes sense. There's a lot of tumor for the immune system to recognize and then respond to if immune therapy is successful. In terms of the adjuvant nivolumab data, the idea, if someone has high risk features, the reason for recurrence is there's microscopic disease remaining. And the idea of chemotherapy and radiation potentially being immune suppressive, we potentially obviate that by giving the nivolumab prior. But that can be challenging. I don't know if other folks deal with this, but in terms of getting pathology back and then being able to start immune therapy, I think it was 2 weeks was the way the study was designed. Correct me if I'm wrong. Prior to starting chemoradiation really can make some tight timelines. So I think in the real world, we may see those the timing be violated or just be somewhat different.
Yeah, thanks. I agree. And so there's no question now that this is the standard of care to get perioperative immune therapy if you have locally advanced disease and are getting surgery.